good morning.
Hi, good morning.
Good morning,
Good morning.
안녕하세요.
Good morning, Ewart.
Good morning.
Good morning, colleagues.
Good morning, Georg.
So
good morning, Malte.
did you hear this guy already? I mean, he's half Korean already.
Yeah, that's right. Yeah, we have fellows.
He doesn't enjoy only Korean diet, although.
Yeah. Well, thank you very much, George. Thanks.
Okay.
I know it's early, and very much looking forward to a wonderful transmission. We have a full audience here. It's a beautiful day in Seoul. Here with me is SJ, David Cohen, and James from Vancouver, with many other good friends on the panel. So thank you again for doing this transmission, and we're very much looking forward to an excellent presentation. Remember, I told you a quick email, mitral clip is not approved in Korea yet. They hope to get it by the end of this year or beginning of next year, right,
Yes,
SJ?
right.
Yeah.
Okay, first of all, I'd like to thank you for joining us every year. It's a great honor for us. All right, you wanna?
Thank you.
Okay. Yeah, thank you very much. It's a great honor for us. It's on our side. Thank you for the invitation, and just would like to briefly introduce the team. Jan-Malte to my right doesn't need any introduction. There is Dr. Markowski in the back from the anesthesiology, because we are doing this mitral clip procedure in general anesthesia. And then there is Marcel Weber on the echocardiography. He's going to be in charge for many things during the procedure. And with no further ado, Marcel, maybe you could introduce the patient.
Yes, good afternoon to Seoul. I'd like to summarize the case. We plan to do a transcatheter mitral valve repair with a mitral clip system. The patient has no previous myocardial infarction or CABG. Her last coronary angiography showed no coronary artery disease. She has other diseases, permanent atrial fibrillations. She has had a dual chamber pacemaker. She got a replacement in June of this year. She has a chronic kidney disease with a glomerular filtration rate of 35. And she has gastric angiodysplasia and has recurrent GE bleedings during the last months. As comorbidities, she has hypertension and has a positive family history for myocardial infarction. She's 72 years old, and her scores are, as most important, the STS score with 7.75%, and the CHEST-VAS score is 4. She presented with severe dyspnea with NYHA class 3 till 4. Next slide, please. Her ejection fraction is moderately reduced, and she has a severe functional MR with an error of 0.37 square centimeters, and as well she has a severe functional TR with an error of 0.5 square centimeters. So we plan to treat the functional MR with mitral clip. Next slide, please. Here you see the difficult anatomy. On the middle moving video, you see the small posterior leaflet and a huge vena contractor you see on the commercial view on the right side. It goes through the whole central commissure of the mitral valve. So may I summarize on the last slide? We have a difficult anatomy, and our teaching points will be to choose the right clip, the smaller NTR versus a bigger XTR. We have a difficult grasping situation with a short posterior and tethered leaflet, and we try to get a very good result, and we have to balance between optimal MR reduction and prevention of mitral stenosis. Thank you.
Well, thank you, Marcel.
Thank you very much, Marcel.
So it's a complex. I mean, it's a more or less regular case. Most of the mitral clip cases are complex and are not straightforward, and there are a lot of comorbidities in most of the patients. So any questions from your side or from the panel, or any suggestions?
Yeah, Georg, the tethered posterior leaflet is certainly a challenge. We know how good you are in that, and we very much look forward to having this. I mean, there are cases that are maybe a little bit more straightforward. This is definitely, I think, a little bit more complex, something that you're facing every day. But any other comments, James, David?
This is David Cohen. The question I would have for you is about the medical management. As we've learned from COAPT, optimizing medical therapy before proceeding to the mitral clip seems to be a very important factor. So what do you do to ensure that the patient is maximally treated with the medications?
Usually the patient has to be on stable medical therapy for at least 3 months, and this patient is on. It was shown on the last slide, or slide before the last slide. Patient is on loop diuretics, on beta blocker, and also on ACE inhibitors in appropriate doses. She is not on Entresto, on an ARNI, because she couldn't stand it for blood pressure reasons so far. She is quite a typical patient for this, because she's not only suffering from a moderate to severe left ventricular ejection fraction problem, but also from mitral regurgitation, and most importantly from tricuspid issues. And in my clinical experience, these patients who do have more than moderate TR, it's sometimes really hard to get the patient on the guideline defined doses of heart failure medication. So, for example, an ARNI of 2 times 100 milligram per day is almost impossible in such a patient for blood pressure reasons. And even when we started here, the general anesthesia, she had a blood pressure of roughly about 80 systolic, and now she's already under norepinephrine, I think 8 to 10 micros, and she has a blood pressure of 100. So to make a long story very short, it's extremely important to have the patient on stable medical therapy, but sometimes it's really cumbersome to reach the right doses.
So, Georg, I just come back from Brazil, and Brazil is in the early phase of the mitral clip, and we have seen some very strange things, to say the least. When you approach a case like this, you know this is an ideal case, this is a little bit less ideal, and those are not good cases. If you plan this case and say, I'm going to do this case, do you have a thought about how many clips you're going to be using, or are you always starting to do the very best with one clip and then see whether you need a second one?
Yes, I come back to that specific question in a second. What we do nowadays is we have to have an idea what are the options for the patients besides mitral clip. If the patient could receive a cardioband, he could be a patient for a valve replacement, and before we embark in the procedure, we should know about the options of the patients. And I'm telling you why. Because once we have placed a clip, let's say we place the first clip and the result is not very favorable, if we leave the first clip there, we are at risk that we are having a situation with no bailout other than open heart surgery. And therefore, first of all, we need to know what other options are available for that patient. And in many patients, we don't have the option for valve replacement, for LVOT reasons whatsoever. Yeah. And many patients are not candidates for cardioband either. So, but if we all agreed that this patient has only the mitral clip option, and this is one of the patients here on the table, she has so far only the mitral clip option was screened out, as far as I know, for all the other procedures. We would start with a one-clip approach, but for example, in this particular patient, it may be difficult looking at the really white regurg we have seen on the previous videos. So if we couldn't do it with one clip, we would start at one side of the jet of the regurg, and typically we do that on the medial side in order not to get more entanglement with the second clip on the medial side.
Right.
But we have to find out, we have to try. And one very important rule is try to place the first clip, if you won't be able to do it with one clip, on one side, that you don't have enemies on both sides. If you have then once placed the clip and you have a medial and a lateral jet, it's gonna be not easy.
I know you're
and the
very
last thought is especially in that patient, just one additional thought, then we stop talking, is she has a gradient already. So she goes in this procedure with a medial gradient of 2, which is not a problem.
Yeah.
But she may be not applicable for 2 or 3 clips.
Right.
I have a
Okay,
question.
James.
Hi, James from Vancouver. Actually, I'm a surgeon. So I just wondering, sounds
Hi.
like this etiology is a chronic atrial fibrillation caused the dilatation of the mitral and the tricuspid annulus. ALV is not really so dilated. I think etiology is a really chronic atrial fibrillation. So it sounds like this is not really optimal for mitral clip, and particularly this patient has a severe tricuspid regurgitation. So I just wondering what's the main contraindication for surgery in this patient? If we are talking about the option, I think whether surgery is really not an option or the any bailout with the surgery in this case, in case not successful. I just wondering what do you thoughts about the surgery?
Yeah, interesting question. I think the underlying etiology is a dilated cardiomyopathy with concomitant atrial fibrillation. She has at least moderately impaired left ventricular ejection fraction of 40, and she used to have ejection fraction of less than 35 in the past, if I recall that correctly. And therefore, the etiology is a cardiomyopathy. And I would give the question back to you, what would be the indication for open heart surgery in a patient in which you don't have indication for concomitant surgical procedures such as CABG? I would say 0.
For this patient, there is a particular with
to be a bit provocative.
Yeah, I think it's a good question. We are talking about ischemic MR, and then the function MR is a little bit different. If it's ischemic MR, yes, there's a different approach, but we just think about functional is non-ischemic. That's the behavior is different actually. So particularly with tricuspid regurgitation, this kind of patient, chronic renal insufficiency sometimes due to the tricuspid regurgitation, because the very common is due to the venous pressure increase and the renal function is reduced. And you correct the tricuspid regurgitation, renal function actually recover. So for this patient, if no specific contraindication for surgery, I think this can be still the bailout for the option for this kind of situation, because it sounds like it's a little challenge mitral clip, and also you have a small gradient, as you mentioned. You probably won't be able to put 2 or 3 clips in this case. So I just, put this on the table, whether this is could be the bailout.
James knows he has to smile to me now because I disagree with him. That's why. That's why we're discussing this here. Let's say you do the clip, and I think actually it is probably a better choice. I know it's a challenging case and probably not something for beginning or for beginners or physicians that have not much experience. For George, I would feel very comfortable. Just, I hate to bring it up, Georg, but what do you think about the tricuspid situation? I know that you have that in mind, at least in your second thought. What are you going to do about that? Would you wait for the result of the clip and then eventually maybe tackle the tricuspid, and what are you going to do with the jet score and atrial fibrillation and things like that? Could you just summarize that for us? You're smiling, I know.
Let's try to do let's try to do the mitral clip first, and If we don't run into a catastrophe, then we can talk about other issues in a second from now. But you are raising the right points. I think tricuspid needs to be fixed at some time. We know that these patients don't benefit if you don't fix the tricuspid, and only in 60% of the patients you have a benefit in the tricuspid situation after you fix the mitral. So I would say this is a two-stage situation right now. We are lacking data, and I would do first the mitral in that particular patient, and then maybe in a couple of months, if we don't see improvement in the TR, which I would expect that we don't see, then we would do the
that
TR.
was really my question. But I can see you're very relaxed, and that's good for the patient and good for us.
Yeah, let's see what happens. Thank you so much. I'm relaxed because I have you on my side in Korea. So
I'm going to hit both of them here.
Maybe, please. Maybe you could do that just as a preventive stroke. So let's explain what we have done so far. First of all, you have a venous puncture. This is very trivial, and then you go into the right atrium, and obviously you have to do transeptal puncture, and this is very important because you have to have a certain distance, and you have to have a certain position for the transeptal puncture, and we do that echo driven. And if you could go to the echo, is this the first attempt or the second?
This is the anterior posterior view of the septum.
Yeah.
And there you're hitting the septum and tenting a little bit, and you try to be in the middle or more posterior. You see here the aorta, and on the next.
So you want to be posterior, but sometimes if the heart is very large, if you are too posterior, then the distance to the mitral is going to be too far, and then you're not going to be able to reach the mitral valve with your clip. And therefore we need to do measurements. Maybe you can show that.
This is now a 4-chamber view, 0 degrees in TOE, and here we have the measurement, and the distance is from the puncture to the middle of the closed mitral valve is 4.8 centimeter. And this is a distance which is quite good.
Yeah, so we are aiming at a distance between 4 and 5 centimeters with the NTR clip. And we confirm this after transeptal puncture. Maybe you can show the transeptal puncture.
Here's a transeptal puncture shortly after. And then we
measured
again, and here we have 4.5 centimeters to the middle of the mitral valve.
Okay. So then we did the transeptal puncture, we exchanged with a stiff wire, and then placed the mitral clip sheath. That's a 24 sheath guide, which is sitting now in the left atrium. There is we have a second line in there. If you go to fluoro, once we did the transeptal puncture, we advanced 2 wires, one wire for the mitral clip sheath, another wire for a pigtail catheter, because with this we can simultaneously measure left atrial pressure. So one goes for the pigtail, and the other one for the mitral clip sheath. And that's the situation right now. If we go live, you can see the mitral clip sheath sitting in there, the TOE probe, and the pigtail catheter in the pulmonary vein, in the left upper pulmonary vein.
Georg, are you doing this routinely, the pigtail catheter monitor left atrial pressure routinely, or only in certain cases?
To be honest, not always, but in a patient in which you start with a gradient, I think it's a good advice to do this.
Okay.
I mean, there is nothing wrong about doing this. It always helps. But sometimes if you have multiple cases per day, then you cut back on the procedural complexity.
Yeah.
So this is the clip, and you have to, now we're gonna.
Can you say
put
which
the
one
clip
you're using?
on the. This is a small clip, the smaller clip, I should say, the NTR clip.
Yep.
Why? Because maybe Marcel, you can show, maybe can go to echo for a second on an X-plane view. If you look at the, maybe you can measure the PML, the posterior mitral leaflet. If you look on the right side video, you see the posterior leaflet on the left side there. Mm-hmm. And this leaflet is not too long. It is probably somewhere around 1 centimeter. I think that was exaggerated a bit. And there's kind of there's some tethering of this leaflet as well, which is a typical finding. And then we also this would be one argument against the larger clip, a small PML. And the second argument would be that we have already a gradient, and therefore we're gonna start at least with a small clip.
Did I miss
if
that?
you
What
won't
was
be
the
able
gradient?
to grasp
What was the gradient? Theo?
between
Two,
2
I
and
see.
3,
Okay.
between 2 and 3, 2 and 3,
Yep.
2.5, wasn't it, Marcel? What was
Yes.
it?
Yeah.
Yes.
Yeah. Okay. So now we have the system in place, and we advance it through the
On
guide
the echo, you
catheter
can see
into the left atrium. Yes, Marcel.
on the echo on the left picture, you can see the clip coming out of the sheath.
And
You
now,
can see here the sheath, the end of the sheath, and the clip is coming out.
yeah, beautiful. And now we're gonna bend it down to the mitral valve. Sometimes you hit the left atrial appendage. You shouldn't do that too hard, because then you're gonna have a pericardial effusion. And there you can see already the clip on the mitral. So from this point on, it is more or less only an echo-driven procedure. We are, as you can see on the left side, we are on the lateral side of the commissure, so we have to pull the whole system back. Maybe we can have a look at the sheath for a second. So question is, how much space do we have for the sheath sitting in the left atrium? And there it is still 2 to 3 centimeters in. Yeah. Okay, and now we have to position the clip in appropriately and accordingly to the jet we have seen before, and we will check this again. We are a bit on the flat side. If you look on the right side, therefore I did some manipulation on the sheath catheter. And now we are not too bad already. I can give up a bit of the M knob. The M knob is important for the bending of the catheter. You can see this also on fluoro, but maybe fluoro is not so instructive. We don't need this. Yeah. So
you're giving it a little bit of
M knob. Can you see the M knob? Yeah. Just to show you. And now I think we are not in a bad position, and we're going to open the clip and look for the orientation. The clip has to be, if you will, in 90 degrees or close to 90 degrees to the margin of the leaflets, to the coaptation. And here you can see already that this is not gonna. Yeah. Now this is done usually in 3D.
Yes.
What you can see, the most challenging thing is the imaging. I don't like the imaging in that patient. We don't have stable imaging, so it's not going to be so easy, especially for Marcel.
I try to do my best. So
We
you
know,
are
Marcel.
hitting 12 o'clock.
Can you give a bit more gain that the audience can see also the mitral?
I try to visualize the whole mitral a little bit better. Now it's better.
So can you see?
Here's the aortic valve. It's usually at 6 o'clock of the mitral valve. Here you see the anterior leaflet, and behind or above you see the posterior leaflet, and the clip is heading just between A2 and P2 and heading to 12 o'clock.
Yeah. So if I can turn it like this or like this, and I would say this would be a nice orientation for the clip. You agree?
Yes.
Malte, Marcel?
Yes.
Okay, then let's go back to the explain. Yeah, please, go ahead. Eberhard, you had a question?
No, I just...
I'm advancing the clip into the left ventricle. Yeah, please, go ahead, if there's any question from your side.
No, it's everything
This
is
is
good.
a very calm procedure,
we let you concentrate
so we can
and work.
So please look at the right side. There you can see that the anterior leaflet is lying on the
Sits on
clip, and the posterior, I think so as well.
Can we double check orientation first?
Yes, of course.
I think the clip, sometimes the clip moves, it turns a bit if you go into the left ventricle, and you can check on fluoro, but we can also check on 3D. So you can see we are a bit more counterclockwise, and I correct the position by a bit of turn in the clockwise position. I did that already.
Increase the image a little bit,
okay.
Gain, which it comes a little bit weak.
Oh, sorry, yes. The 3D image.
The 3D image, but
no, 3D is fine.
so my question, Georg, was you basically start in the between A2 and P2, right in the middle, just to check out.
Yeah, if possible. Yeah, if possible. I think now both leaflets are on.
Yeah, you're very medial, and the posterior leaflet is perhaps a little bit curved. It's difficult to see.
In.
Here.
Yeah, still, let's go. Let's try.
Sorry, yes.
Close.
So he's closing.
So
he's
maybe
closing
you can comment what you are doing.
I'm putting down the grippers, and now I'm closing the clip. So now the clip is closed. And we can assess our result.
So, as you can see on the commissural view, we started a bit on the medial side.
Yeah.
If you recall the initial images, that's where the jet started to go back into left atrium, and therefore I choose to start right at the margin of the regurg. But we can always reposition. There's a lot of lifting of the anterior leaflet, as you can see. Maybe you can see color.
Yes.
But it looks like you. Oh.
This
looks better.
This
That's
looks already
very
very
nice.
promising. But I don't trust it right now. We need to really check in all positions.
Yes.
How's your left atrial pressure?
It didn't. I should have shown you this because. Is it on the screen? No, it is not.
Could we have the hemodynamics on the screen?
It's still pretty. The V wave is still pretty high. It's
Maybe Before it
Yes.
was 35 millimeters mercury. But
Sorry, we should have shown you this. I'm sorry, I forgot.
We'll forgive you.
So I have one jet which is going through the clip, and I'm not sure if it is medial or going through the clip. And
Yeah,
the
can-
other jet is along the commissure. You see here, but it is very small.
This is very small.
Yeah.
We have a blood pressure of 110, close to 110. This is also very important. If you assess the MR during the procedure, be sure that your blood pressure is okay, that you don't assess at a blood pressure of 70 or so.
But the
But can we do 3D?
LA pressure came down, right?
Yeah, please, Eva.
Yeah, the LA pressure came down.
It came
to
down, yeah. It came
twen-
down
to 24.
What was it when it's
35.
10 millimeters of
10
mercury.
millimeters
Yeah.
of mercury. From
I mean-
35 to 25.
I mean, that's not a very bad V-wave.
No. Well, considering the first clip, that's amazing.
Yeah, that's amazing. I wouldn't have expected this, to be honest with you. Maybe we can see also color, because Marcel wasn't sure about the origin of the residual jet, and sometimes 3D helps. It doesn't help you to assess severity, but it helps to find out about the origin of the regurg.
So
Maybe Marcel, you can comment. It's lateral, right?
here's the lateral jet, and there's something going through the clip. I try to tilt it to have an idea if it's going medial or lateral, but
So
I
lateral
don't see
side is on the
medial.
right side, just for the audience, and medial
Here's
is on
lateral.
the left side.
And here's medial.
But I don't see anything on the left side.
Seems that
Where do you see the jet?
Yeah,
I don't
that's
see
right.
the jet.
I d-
There's a small jet,
Yeah,
this
yeah.
yellow, this reddish color. That's a
Yeah, yeah.
small jet, and it's coming very close. It's adjacent
it's
to
small.
the lateral part. It's very small. Yeah, it is very small. But most important right now is that we don't leave a jet on the medial side behind, because it's going to be not easy to put another clip on the medial side.
Yeah,
So
very good point.
my strategy, my recommendation would be, this is so far a good result. Could you go in the neutral position? Is a good result. If we don't have an increase in the gradient, we
We know
would
how.
leave it. We would leave this clip there and set it free, and then look for the evolution of the lateral regurg. And probably we're gonna put another clip right lateral to this one, if the gradient allows this. And it seems like this, yeah. So, yeah, we have a gradient of, can you see? Yeah.
2.3.
So it's the same, which is not untypical. If you of course, if you lower regurg, you lower the volume, as you all know, the blood volume, which goes through the mitral, and therefore, even if you put down the mitral orifice area, the gradient can stay the same. So if you agree, Marcel, what do you think?
My only concern is the lifting of the anterior leaflet. I believe it's very large, the anterior leaflet, so
I
it
wasn't,
will lift anyway.
yeah,
But
I wasn't able to pull harder. That's all I could do so
Mhm.
far. So I would say we leave it there, and then look after the results, and then probably place a second clip in
So-
order also to stabilize the whole situation.
So while he's doing this, and yes, I am biased because it's our center, it's my friend, but seriously, I can tell you one of the most important lessons that I've learned is that you can see here. Be very critical with your own result. Don't simply believe in what you see and say, well, this is good, let's finish it, and then go. And I've learned that actually from Georg. He's extremely patient. I'm actually much more, if I'm standing, would have stood next to him, I'd say, well, perfect, that's good, let's do it. No, he waits, he lets the pressure develop, and I think that's the right thing to do for the clip. Let's see how the leaflets behave under the clip situation, how the pressure develops. And I think it is very important not to be too impatient, but much rather be patient with that procedure. And, you know, I mean, we never thought, but all of us didn't think that would have been the first clip would do something like that. And yet he's still critical, looking whether or not he has to put a second clip on the other side. David?
No, I think, I think a lot of the time what you see is, once you release the clip, is that, I mean, there is a change in the anatomy, and the degree of mitral regurgitation will increase somewhat when you release the clip from the...
Still, there's a lot of motion in the anterior leaflet, right?
Yeah, there is.
James, what do you think?
I would say...
Go ahead.
Pretty good.
Go ahead.
To me, the first clip and it looks pretty amazing, actually. Good.
Just one question. Do you think the length of the tissue grip by the clip at the posterior side is enough? I mean, is there any practice to measure the length of the leaflet that is clipped by the mitral clip?
I think it's very tough to get much more grip on this than he's got. It's a short, one of these real shrunken posterior leaflets. It's so common. Yeah.
Nice up. This is really an educational case because I think we have a leaflet detachment here.
Yeah.
Can we have a look first at the sheath?
That's what I thought with the anterior.
I think we are way in. You always have to check that you're still in the left atrium.
Here it is.
Yeah, it's
Here the end of the sheath, it is 3 centimeters in.
So now we have to get rid first of this clip and then check what's going on.
In the commercial view, it is quite stable. I think it's a partial.
Is it a partial
attachment? The anterior leaflet is still in. You see it on the right
but
video.
I could tell already from fluoro that there is something going on, but no problem. So far, we're going to place a second clip, and this clip still does somehow a drop. Yeah, I can show the fluoro. There's a lot of movement.
Oh wow! Yeah,
which is not typical. Let's get the second clip. Zweiter Clip. Last time we made the transmission, we weren't able to get the gripper line off the device. Yes. Do you remember? So it's always special to transmit to soul.
I do remember that.
Do you think something changed as you were releasing it, or you just didn't have as good a grip as you thought?
Yeah, probably we had a lot of tension on the system, and that held the clip in position. And now we have at least lost some grip, probably on the anterior leaflet. Can we see color?
Yes.
And there is more on the lateral side, as you can see.
Yeah.
And first of all, we're going to place, a second clip on the lateral side. So let's go back to the...
So, plan now, Georg.
Clip is coming out.
Yeah, plan would be to place a second clip first of all on the lateral side because that's easier.
Yep.
Than trying to cope with the medial shed. There was also recurrency of a medial shed, as you could have seen, as you maybe have seen. So first of all, we're going to check the medial jet, the lateral jet, and We need to have the right image, and we can tell also from fluoroscopy. If you look at fluoroscopy, lateral would be up to the former implanted clip, and medial would be down towards the lead of the pacemaker.
Yeah, so the clip is not free floating, thank God. So it's probably partially detached, right?
Yeah. Yeah, if at all. Maybe it probably still hangs on the anterior leaflet. So this is not a problem so far. Can you open the clip?
I think you're quite near to the older clip. Now you are more lateral.
So let's check orientation for a second. So we need to be a bit more on the 12 o'clock alignment because we're going to be a bit more lateral. So right at the P2, A2 area.
It's 1 o'clock right now?
Yeah, this is fine, I think. Please close the clip a bit. We're gonna go very close to the other one, and therefore we close the clip a bit. And we have stable imaging on both sides. I don't see the former clip on the commissural for you.
It's just beneath. Do you agree? On the commercial view, you're just above the older clip.
So we are in. Open, please.
Yeah.
You have fluoro also, yes. So we are very close to the other one, and we can go even a bit closer. And now we need to check.
The clip is very wide open. It's almost 180.
You can close the clip a bit.
I'm closing the clip.
Yeah.
A little bit.
So now we need to have a perfect image on the LVOT side.
Yes. The PML is not on. I try to make it better.
Let's go only to LVOT.
Okay. Only LVOT?
Yes,
is this better right now? Yeah,
please.
okay.
Because we can see on fluoro also the commissural view because we have a landmark with the old clip. So we can stick for a second only to the LVOT side because he has a hard time for perfect imaging.
So both are on, or? Do you agree?
Now it looks not too bad. I'm not so sure about the anterior leaflet, to be honest.
Yes.
So now it's better. Yes, I think we can close. We can try.
I'm lowering the grippers right now. Now I'm closing the clip.
No, you.
It's quite under tension.
Yeah.
The anterior and the posterior.
Yeah. You can see also a bit of dust in the left atrium. We have a V wave of 24.
Looks like you got the
check first of all before we look at anything. Yeah, let's check the leaflet insertion first, really very carefully, to be absolutely sure that we grasp both leaflets. But you can tell here that we have there's a lot of tension on both leaflets. Can you see this?
Yeah, we can see that.
If you look on the right video.
Yeah.
Yeah.
It's almost a straight line.
I released already the. And if you look on fluoro, the other one is calm, because somehow we fixed the other one also. So let's have a look at the regurg.
Yes.
So.
Georg, can you show us or Marcel, can you show us the initial mitral regurgitation when you started out?
Yes.
Yes, in a second. Let's check this for a bit more.
So we have this medial jet, medial of the first clip.
Yeah.
And I think this is the only big jet left. We have some small jets along the commissure.
We have a vena contractor of probably 2 to 3 if we measure. So this is also, yeah. But please check also the lateral part of the.
Yes, of course. I screen the commissure.
There's a small jet also on the lateral side. There's a very small one, very lateral. I mean, we don't have to talk about this one, yeah. But there is a small jet right lateral to our
to the new clip,
jet,
yes.
Yeah. Our actual clip.
I think this is the one.
But you can see this is the vena contractor is probably rather small, and the jet doesn't even go to the ridge, so it's not going to be a big issue. We're gonna check for a while again, and we check. He's checking the gradient.
But that looks probably good.
.8.
Yeah, maybe a bit more.
Yeah.
You cheated a bit. But it's not above 2.5. It's not above what we had before. I think we can all agree. We can all agree on this.
So I have the baseline image before the procedure. It's now on the screen.
Yeah.
So you can see that it's along the whole commissure.
Yeah, thank you very much. That's
okay.
Just to compare it.
So Marcel, go back to the explain image and recheck the leaflet insertion of the actual
new clip. Yes.
Yeah. Because I'm quite confident with the results so far, and here I'm more comfortable also with the grasping.
On the anterior.
There was a question from the audience. We are from both sides. There was a question from the audience. Can you measure actually the leaflet insertion into the clip? This is, as you can see on echo, not so easy because of the resolution and the movement of the device. What we sometimes do, we assess up front the leaflet length and then check how much leaflet is still sticking out of the device, out of the clip. I mean, this is a poor man measurement, admittedly, but that's all we can do because we are not able to visualize the leaflet between the clips, right?
Right.
Marcel?
Yes, it's very difficult. I'm sorry for the imaging. I would like to show it better, but perhaps it's...
yeah, but it's not bad. It's not bad for you.
Yeah. Yeah. Sometimes you can see it better. How many leaflet is grasped by the clip, but in this patient,
but you could see, Eberhard, you recall that we have 10 to 11 to 12 millimeters of posterior mitral leaflet.
Right.
And there we have only a couple of millimeters between the clip and the, this is exaggerated. We have probably only 3 to 4, maybe 5 millimeters.
Yeah.
So probably 5 to 6 millimeters of the posterior leaflet are inserted into the clip, which is quite good.
Very nice.
And on the anterior side, I would say there is such a straight line. Maybe we can check on 3D for a second.
Yes.
Shall we get back to the neutral
On the
position?
previous
Yeah,
image, I
please.
just
And
didn't see on the
recess
3D, I
mitral
didn't see the first clip.
regurgitation.
It's not so easy to sort this out because the other clip is a bit, it almost is in 90 degrees, so there's a lot of shadowing.
This is the old clip here.
Yeah.
Yeah,
And
I turned the gain down, then I can see it better. And this is the new clip just
Yeah.
in direct, and you can see that the old clip is more heading to the posterior leaflet because it
Yeah,
is
that's
not
what we expected.
attached
Yeah.
too much to the anterior, and
Yeah.
this is just between, and you can see the bridge between anterior and posterior.
I think we can leave it there and then show you what the result is after releasing this clip.
So
Hopefully
you
it's gonna
release
be better
now.
than after the last clip. Yeah.
Shall we reassess in this neutral position?
Yeah,
Any-
let's
any
reassess.
comments,
Good
guys?
point from Malte. We go to
Any comments?
go to
I just have a
Yes.
question. I think the result's good. The one thing that question is right now the jet is actually median to the first clip, and the first clip we know is not so stable, and the second clip was really helpful to hold the two leaflets together. So within time, do you think this will be a problem with the first clip, or because the regurg jet is actually median to the first clip? Is there any issue, or need another clip to secure the first clip?
A good point. I don't think that it will change over time, that there will be a worsening, because it's a too tight anatomy there. But we will recheck after releasing this clip, and maybe we'll opt to go for a third clip in on the medial side. So your question is well taken. But I think first of all, we should release this one and then double check. But we are not done yet, so maybe we need a third one.
I'm Young-Ko from Severance Hospital, South Korea. I have no experience with the mitral clip, but how do you define the optimal result after mitral clip? So how much residual regurgitation is permissible?
I mean, you should always try to be as good as possible. So if you have MR, a trace or MR1, this is a perfect result. But sometimes you just have to be, you have to be okay with an MR2. But we know from all the data that one of the most important predictors of poor outcome is residual MR. So try to be as meticulous as possible and try to bring it down as much as possible. So this would be the rule of thumb. And how to assess, this is not so easy because there is a division. Sometimes you divide the jets by the mitral clip, then you have to add the arrows, the vena contractors. Maybe Marcel, you can comment on this because you're more expert in this.
It's very difficult to count the arrows and to measure it in 3D. So it's not exactly measurable.
Yeah, to be honest, there is a bit of eyeballing also. We don't like this, obviously, but that's how it is.
I think the other piece of data, I mean, there
So
were
now
data
the
from
clip
the...
is
Go ahead, Georg. Go ahead, Georg.
No, please go ahead.
Oh, just the data from the COAP trial did suggest really almost no difference between 0 and 1 plus residual, and perhaps a little bit worse with 2 plus, but even 2 plus was quite acceptable and had a real benefit in the COAP trial. So I think you don't have to go for perfect. If you happen to get perfect, that's great, but it doesn't have to be.
Yeah, well, I can tell you, George is trying.
Yeah. I know. Sometimes you can't.
To get it to perfect. By the way, Dr. Ko, who just talked to you, can also speak German to you.
Okay, why not?
No one else will understand.
So now the clip is released and we can check the result.
Yes. the media clips seem to move a little bit more than before. You agree?
Yeah, but show us the color.
Yeah.
We have this medial stuff, and there is...
but the color is the same, I think.
Yeah, it's maybe a bit more.
Don't you think the jet is a bit more?
Yeah, it is a bit more. Let's see without color.
Yes.
Whether we will be able to place another clip on the medial side. This is not going to be so simple. We need to check in 2D. Now he's putting the cursor on the commissural view right on the medial side, and you can see the leaflets, what we would have on material, to crabs on the right side. Could be doable. I think we should try to make it better.
Mm-hmm. How much do you worry about the chordae when you're way over there?
I do worry.
Yeah, okay.
I wouldn't have told you if you wouldn't have asked me.
I worry too.
So this is.
But we do worry, yes.
This is Anthony Wong from Hong Kong. So I noticed that the jet is very medial, and it would be actually very, very difficult to put it there. But in order to stabilize the first clip, in case you cannot really put the third clip at the medial side, would you consider putting an additional clip on the lateral side just to help stabilizing the first clip?
I don't know, because if you look at the image, then a further lateral clip would be even more remote to the bit unstable clip. I don't think that this would change the situation, the motion of the first clip, of the very first clip.
Yes, I agree very much, but
maybe
would it be very dangerous to put the third clip very close to an unstable clip?
Yeah, maybe. I think if we are cautious, we could do it. We could try. The problem is once we're into the left ventricle, we're probably not going to get out. So we have to place it somewhere there. This is my major concern. But right now, the result is not bad, but it could be better. And therefore, I would go for it. Let's give it a try.
Are there any special tricks to going this medial? Other than be careful?
You have to be careful. You have to be coaxial. So we have to double check the trajectory of the catheter, commissural wise, and also in the LVOT view.
Clip is coming out.
We have to enter the left ventricle in a closed position, and we're probably not going to open the clip in.
I think you're heading to the pulmonary vein.
That's very interesting. See the motion.
So
the motion difference between the first and the second clip.
You are very medial and anterior.
I changed. I modified the positioning.
Yeah.
So now I should be a bit better. Now we need some imaging, and we get a bit closer to the clip.
You're
which
still
makes
medial there, and but central on the right view.
Georg, are you looking more at you're looking at echo, right?
Only.
Yeah, both right now, because we're getting a bit closer to the.
Now you're coming more to the central.
Oops. Yep.
Oh no, we are still far away. You can tell from fluoro here. We are still okay. So half a centimeter. So, but now we need to see on fluoro, on echo.
Yes.
because trajectory is very, very important. Let's show us the two clips in position and don't worry about my clip.
Okay.
The clip which is on.
Here are the two clips, and you are just in the knee.
Okay, and the other one is close by now. So, can you see? So the third clip is right at the mitral on the medial side, a bit on the posterior side, but we can check. Let's open the clip for a second and check the orientation. We have to be somewhere at 10 to 11 o'clock probably.
Opening the clip.
So now you are near to 12 o'clock, but I think it's more to 1 o'clock, not to 11 o'clock.
No.
Do you agree?
No, we have to go to the medial side. So I'm tilting it. I'm turning it a bit.
Okay. So now it's 11 o'clock, I think.
Yeah, this is fine. Let's close the clip. Now we have to wait for imaging. We need to see all three of them right now.
Yeah.
Do you think it would be beneficial to get a ventilation stop, or?
Yes, we will. Yeah, that's a good point.
Could we have a ventilation stop? Atmung einmal aus, bitte.
I can show the two clips, but I'm not.
So
now you're in, yes, perfect.
Yeah, and now we open the clip. You can see it also on fluoro. Just don't have to open it totally. That's fine. That's fine.
I think.
Yeah, let's check orientation. Because we see the clip in total on the commissural side, that always makes you suspicious that there is an issue with orientation.
I think 10 o'clock.
Yeah,
you
now
changed
it's better.
it a little bit,
yeah,
yes,
I
perfect.
turned it a bit, so now it's going to be fine. So I'm trying to get a bit closer to the former one. And now we need to see, maybe you can go only to LVOT, because I can see the I can see the vicinity to the other one on fluoroscopy.
Yes, I have to change it a little bit. Now you see the LVOT as well. I think the PML is on, but not the...
Maybe you can open it a bit more. Yeah.
It's both on. PML can curl a little bit. Sorry, I lost it.
But now it's fine. Close.
Going down. Now the clip is closed.
I guess there's going to be Beatmung, respirator can go on. We are a bit far away from the previous clip, as you can see on fluoro.
Yeah.
So we are very, very medial. But in this situation, first of all, you need to grasp what you get, and there's probably some residual jet between the first clip and the third clip. But let's see how color is evolving.
Okay, I think the grasping is good. Do you agree?
Yeah, grasp is fine.
Okay.
I think so too.
Color is coming.
If we could see
all three clips, yes.
Yeah, is it possible to get all three clips in line?
In line is difficult. I think that they are not all
they are not
three in line.
Yeah, true.
But there's still this jet medial of the first clip. But it is perhaps a little bit smaller.
But it's smaller.
Yeah. So I try to visualize all three clips on the left image.
Are you still on? I can't hear you anymore.
No, we are just, no, of course we're on, and we see you.
we're concentrating.
We are concentrating.
They went for dinner because it's German fools. I mean, what they're doing there.
No. We just didn't want to interrupt.
Yeah, we're rooting.
I mean, admittedly, there's still a jet, and this is still MR1 to 2. But right now, I won't be willing to reposition this clip because we have a nice grasp. So there is security also from the medial side now. Though I'm pretty confident that there will be no further recurrency, because we have a nice grasp on the lateral and also on the medial side. So to be honest, I would go for this result, unless we see something more worrisome in the next couple of minutes.
Pressure, anything about the pressure? It's the same?
Pressure is somewhere between 20 and 24, depending on the respiration cycle.
I've seen a few cases where they've put they come back later and put a plug between two clips. Have you done that? Is that something you would consider if it's a problem?
No, probably not. Francesco did this, right?
I think Paul Saraja, I think
he won't do it again.
Really? Paul, I think, liked it. I think Paul thought it was pretty good.
I don't know.
Just a trick.
In this situation, I think it's not worthwhile. It's just a MR1 to 2, and I would leave it at this so far. I think
go to a neutral position to reassess
final result. And just reassess one more time. So how much time do we have left?
15 minutes.
A
Yeah.
lot.
Yeah. Yeah. I think that's all we can get from this very complex anatomy. I think, we're going to release this one.
I think it's...
And then we're all set. I mean, could you show us the initial MR, the baseline MR again?
Of course.
Looking what we are coming from, I think this is a very, very good result.
How is the blood pressure? Is okay?
This is baseline. Blood pressure is 108 to 110.
That's good.
Over 56 to 60.
I mean,
it hasn't changed.
There's no question. That's a huge reduction. And maybe you weren't that much concerned, but I have to admit, this posterior, small, rolled-in, tethered leaflet is not so easy.
No, it isn't. It is not so, no. And if you, in general, this mitral clip business it has some magic to it. Sometimes I don't understand what we are doing, because imaging is not perfect, and sometimes you place a clip and you worsen the MR and you don't know what's going on. It's not as TAVI yet. We are not in that situation, that stage. We have to learn much more about this, and therefore Eberhard always tells everybody that we should get too excited about the co-opt results. They are perfect, but it's not going to be easy to roll this technique out to every cath lab throughout the world, and I totally agree. Sometimes I'm also very desperate about cases where we sit here for 2 hours and the result is just not satisfying. In most of the cases it is, and in most of the cases it's easy and it's especially very safe, but sometimes you really run into issues.
You know, the thing is that I've seen, and this is, for me, this is always fascinating, sitting now on the other side of the ocean. You know, if you start this procedure, obviously there was a lot of consideration. We all agreed that this was not a straightforward case, and the result, I think, is very nice, very good, very, very patient. But if you start a clip somewhere and you think it looks good, and then you keep going, you're chasing the dog's tail, actually. You know, you go a little further, a little further, a little further. I've seen Georg, which I've never seen before, I admit. I've seen 5 clips. You know, I could hardly see any opening of the mitral valve anymore. And, you know,
but still MR.
Yeah, but I think it is, you know, what I actually like, and this is, be patient with it, and, you know, do a good interaction between the imaging person, and Marcel is very experienced. Even if you are getting nervous, he's not getting nervous, which is always a good thing. And, you know, he kind of guides you, but you can see how important the imaging is, the switching between 3D, 2D, the different views. And I think that was beautifully demonstrated. We were actually quiet because we were hoping for you, and glad that we're sitting on this side of the end and not there. But I think the result is very, very nice. Obviously, as I said, you know, I'm biased, so I leave the final judgment to my friends here on the left side and on the right side. But I wanted to thank you again for an excellent demonstration. If I may say, given my age, I'm very proud of both of you, and thank you for doing this. It was a very enlightening transmission, and I'm sure the patient is doing fine. Let's see how we'll be doing in the future. Any final words from the panels? James is not looking angry.
No, I think it's a great job. I mean, going that far medial is not so easy, and so I think watching a master do it is really terrific. And I think, I mean, I do think, from my standpoint, you know, someone who's done, you know, some of these but not a million, is, you know, the safety of the mitral clip is really the special aspect of it, because you can, I mean, again, if you do it well, it's always safe, and that's really critical because it's not always effective. So it's got to be safe.
So, George, one more thing, because we still have a few minutes. When you see and it was surprising to me how calm you were when you saw the clip jumping and partial detachment. When is it when even you are getting nervous?
If you have entanglement in the left ventricle or in the right ventricle, if you do tricuspid cases and you can't get the clip out, this is a difficult situation sometimes, and that kinds of makes you sweat. Usually you can resolve this issue, but sometimes it takes 10 to 15 minutes to get it out. But I couldn't agree more with you and your colleagues. It's a very safe and a very calm procedure. You can always think ahead and step back and think what would be the next step which makes sense. So it's nothing to be too excited about, this procedure.
But you can see when you have a partial detachment and the clip is kind of bouncing back and forth, you can stabilize it actually when you put another clip on the side.
Yeah. Yeah, I have never seen, we have actually never seen an embolization. And if you look at the data from all the trials, embolization is really extremely rare. I wouldn't worry about this, because even if you have just one leaflet attached to the clip, there's such a big bite of the clip to this leaflet. Usually it won't go away.
Yeah. SJ, you had a
I've never seen
question, right?
it during the last 5.
Was the question whether you could recover the clip? No. Okay.
I have one
there's no question.
I want to just, very typical though. What is the maximum number of device you've done?
It's the world record.
Number
Pardon me, what was?
How many clips?
Maximum number of device. Mitral clip.
I think, I'm not sure, Marcel, 4. 4 in the mitral, right? Was our maximal number of clips.
I think 4. 4 small.
Yeah, 4, but not 5. I've never seen 5.
Can you simulate beforehand to see how many clips the patient will need?
Yeah. Okay,
yes,
so
if you have really a large anatomy, and if you don't have any gradient, you know already that's going to be 2 or 3 clip case.
So this is perfect timing. We want to thank you very, very much for a wonderful transmission. Very calm, very quiet. Too sad that you're not here, so we can have a drink. But I all give you a big hug, and let's give him an applause for an excellent presentation.
Thank you so much.
Thank you very much.
Yeah, thank you so much. It was a great honor being with you, and have a very successful.
We will enjoy tonight.
Convention. Thank you.
Thank you.
Yeah, I'm sure.
Have fun.